So for my assigned cyst, I got the lateral periodontal cyst. For clinical description, it's asymptomatic and rarely presents itself clinically, and when it does present itself, it's a teardrop-shaped radiolucency between the maxillary cuspid and the first bicuspid, and you can see that in the picture, which is more of a severe case. For radiographic description, it has a unilocular radiolucency, and it's located between the crest and apex of the alveolar process. The historical description is a rare developmental odontogenic cyst. The pathogenesis of a lateral periodontal cyst may be related to three hypotheses: reduced enamel epithelium, remnants of dental lamina, and cellular remnants of molasses. Laboratory results. The radiographic features may be inconclusive relative to the diagnosis. Other radiolucencies must be distinguished from the LPC. Anatomic radiolucencies such as the mental foramen, maxillary sinus, and the nutrient canals, cysts of pulpal origin, other cysts of the jaws, adenomonas, and other tumors. It may resemble a cyst that develops laterally through a side channel accessory in a non-vital tooth. Occasionally, they may be multicystic and can be called an odontogenic cyst due to macro and microscopic features, and it will resemble a bunch of grapes. For microscopic, the cyst is lined by thin, non-keratinized squamous epithelium with focal thickenings, and here's the picture from the book. So for surgical needs, lateral periodontal cysts should be surgically treated by enucleation or excision. Therapeutic needs, so after it's been surgically removed, patients should undergo radiographic follow-up for several years to check for reoccurrence because the bone is expected to regenerate in the defect within 6 months to a year. The differential diagnosis of an LPC should be restricted to cysts that are located periodontally. Differentiation between the lesion being examined and inflammatory cysts as well as kerocystic odontogenic tumors should be based on clinical radiographic and pathohistological findings. For my patient lesion, my patient had two conditions that contributed to the presence of both lesions that I found in her mouth. She has lupus and Sjögren's syndrome. I did find a mucocele and lichen planus whenever I did her assessment. A mucocele is a common mucocutaneous disease of unknown etiology except for traumatic origin, and Sjögren's syndrome might be one of the important underlying diseases which can cause mucoceles, especially in elderly female patients. My patient was in her mid to upper 50s, so it made sense. So this is the image that I took of her whenever she came in. It's a severed salivary gland duct, and it can affect any age. The area affected is most commonly on the lower lip, which is where this image was. Clinical features include localized tissue swelling that increases and decreases in size. This one was measured to be 3 by 3 millimeters on the labial mucosa. There are no radiographic features. Microscopic features include an extravasated mucus and tissue surrounded by granulation tissue. And then treatment would be excision, but a lot of times these spontaneously resolve themselves. And then diagnostic process would be clinical and microscopic. Next, I found lichen planus, and that is usually caused by chronic friction against the mucosal surface. Any age can be affected and any area can be affected, but it's usually on like your cheek or on your lip. The clinical features is a lacy-like film, as you can see, and then the microscopic features are hyperkeratosis. Treatment would be biopsy of the lesion if it persists for greater than 2 weeks, and then the clinical or the diagnostic process would be clinically. So my patient stated that she experiences mucoceles frequently and that she had just had a lupus flare-up the week prior, and stated that she experiences both lichen planus and mucoceles after flare-ups, and that it's pretty common for her. So that is everything. Next, my sources.